So here we are with the second episode in the Wound Masterclass podcasts. And this one is incorporating innovation into clinical practice. Are you excited about this one, Alec?
Definitely yes. Had some very good feedback after the first episode.
Yeah, we had some really nice comments, didn't we? We're sort
I
of
did.
that people enjoyed that conversation. And for the listeners to this one, if you've missed that first episode, it's downloadable on.
It's available on all the major podcast platforms, and you can find all those links on woundmasterclass.com/podcast.
This is our second in the series, and Alec and I are going to be your co-hosts for this one, and it's incorporating innovation into clinical practice.
There's been lots of innovation, hasn't there, in recent years in the field of wound care. I think it's really quite exciting.
Yeah, it's really remarkable just the speed at which innovation has been brought into particularly wound care, but I guess into also reconstructive surgery and the reconstructive fields. But I think more so in wound care, there's new dressings coming out almost um, at such a fast pace and new technologies. There's new sort of ways of stimulating wound healing for that wound that's stalled or the challenging wound. So it's really, I think that's part of the attraction of this field is just keeping abreast that innovation. Because the speed at which it's evolving is just really, really remarkable. And I think, from our perspective, I guess from me and you, we're trying to find out from our guests today, how do they know which innovation to incorporate into their clinical practice, or how do they go about deciding, what modalities they're going to incorporate into the clinical practice, and essentially, which patients are going to choose timing wise. Do they wait till the wound is at a stage where it's stalled, or try and bring some of these innovations in early? And what about using innovations alongside other innovations? So sort of utilizing the synergy of two new techniques essentially. And obviously all of this is under the umbrella of evidence-based practice and evidence-based medicine. So um, it all has to be supported within that sphere, certainly.
hmm
So, Alec, let's talk a little bit about our guests for this podcast.
Yes, we're joined by Dr. Wendy Cole, who is a podiatrist from Ohio.
Yeah, and joining Wendy is a plastic surgeon called Dr. Martin Johnson, Marty, and he's an interesting expert. Had been in private practice in Phoenix and Scottsdale area for over 30 years and was involved with many multiple hospitals in that area, in the area of wound care, including the Mayo Clinic in Phoenix. But currently, Dr. Johnson's actually at the Casa Colina Hospital and the Centers for Healing in Pomona, California. And there he leads a limb preservation clinic with a focus on amputation prevention and wound healing. And, really interesting chap, isn't he? I mean, he's, decades of experience in this field. He's been a clinician that's been kind of very enthusiastic about embracing innovation in his clinical practice. And it could be, it's really interesting to talk to him about how he decides what kind of innovation to bring into his clinical practice. So that's who we have. So I think it's going to be a great podcast.
Yeah, absolutely. So here is that conversation with Dr. Wendy Cole and Dr. Martin Johnson.
Welcome to the Wound Masterclass podcast. We're really honoured to have Dr. Johnson joining us and Dr. Wendy Cole. So thank you very much for joining us for this session on bringing innovation into clinical practice.
Pleasure to be here.
Absolutely. Thanks.
Thank
This
you.
will be great.
Great. Now we're really looking forward to having a really frank discussion about the challenges of bringing an innovative product into your clinical practice. So, Dr. Johnson, you have quite a varied plastic surgery practice. Are you able to tell us a little bit about your current clinical practice?
Why, sure. Currently, I'm working at Casa Colina Hospital in Pomona, California. It is a primarily a rehabilitation hospital, but there's been a wound and hyperbaric center here for about 20 years. About a year ago, they embarked on developing a limb preservation program, and we are affiliated with Dr. David Armstrong at Keck USC. And he's actually the reason I'm here. I'm a plastic surgeon. I previously was at the Mayo Clinic in Arizona, developing a wound center there. And prior to that, for 30 years, I had a plastic surgery practice in the Phoenix area, Phoenix, Arizona. So I'm probably the oldest one here on the table, or on the offering here today. But so yes, I have done general plastic surgeon microsurgery in the past. I have currently I no longer do cosmetic surgery, and my efforts are devoted towards wounds with a special interest in the diabetic foot.
Interesting. So some of your clinical practice will include venous leg ulceration patients as well as the DFU patients, presumably. And I guess some of these challenging, hard to heal patient groups as well.
But we like to say in plastic surgery that our domain is the skin and its contents. So, you know, it can be anything from currently from a wound due to a skin cancer or radiation, or as you mentioned, venous leg ulcers, diabetic foot ulcers, pressure injuries. We're in a rehabilitation facility here. We see too many pressure injuries. And then some of the unusual, you know, wounds to pyodermic gangrenosum and things like hydroxyurea wounds, et cetera, et cetera, et cetera. So it keeps me stimulated.
Interesting. Yeah. I mean, I think plastic surgery practice over in the UK and Europe is maybe slightly different in terms of the scope of patients we see in that practice. But I guess, you know, over the years, over the decades, you will have used quite a lot of different wound care products. You've got such a vast experience.
I am of enough of an age that when I started in plastic surgery, we used wet to dry dressings. You know, that was the gold standard at that point. And I look back and some of the things that we added to them, whether it was betadine or Dakin solution or peroxide or many other things that we now recognize are toxic to keratinocytes and fibroblasts, you know. So once I started, you know, getting into this wound care space, I was able to learn about many new products that actually help healing as opposed to hinder healing.
I think we're really lucky that more recently there's a lot of biologically active technologies that are kind of entering into the space that are light years above, you know, the wet to dry and the betadine. So I'm really excited to get into some of these technologies and learn about your experience today.
Okay. You know, as I have evolved, I like to say, you know, away from wet to dry dressings, you know, I have trialed many products in the biologic space. For instance, I've used cellular and tissue-based products. When I was at the Mayo Clinic, there were a few restrictions on what you could bring in. I was an early user of the PRP in the form of 3C patch. I did that at Mayo Clinic, and then when I came to California a year ago, I brought that. And then more recently, you know, I was introduced to the synthetic skin substitutes, and primarily what we're talking about today, the boron-based bioactive glass, which if you talked to me this time last year or even last summer, I would have, you know, scratched my head and said, what are you talking about? You know, you can make fiberglass into a product that is absorbable. So, you know, I like to be stimulated by new products if I think that they can offer better patient care and better patient outcomes. Obviously, there are some potential limitations at times. I have a chief financial officer here, and I had one at the Mayo Clinic.
We all have someone like that, don't we?
Yes.
the gatekeeper or the bean counter, if you want to be, you know.
So that does limit, you know, but if you can show them that this is either a product that is reimbursable, or the new products are reimbursable, or that you can shorten patient time to healing it's a little bit of an easier sell, especially if there is science behind it. I think it, you know, it makes it, I think it makes it interesting. As I say, it keeps me stimulated, and more importantly, I'm seeing really strong results with our patients. You know, and you know, I know we're talking some today about this new category that is out there. You know, with the boron-based bioabsorbable glass, and it has multiple benefits. In some form, it's been present in the space, in wound space, especially the orthopedic space, for over 3 decades. So, I mean, there is a track record for, you know, a product like this. And you know, I recently became part of a 12-center randomized control trial to determine its additional benefits in the treatment of diabetic foot ulcers. There was a previous paper that was put out with David Armstrong as the lead author, with an N of 40 patients, that showed a significantly shorter healing time using the boron-based bioabsorbable glass for the treatment of diabetic foot ulcers. So currently what they're doing is expanding it to an N of between 100 and 240. So I'm both happy and excited to be a part of that, and you know, being able to witness some of the benefits that we're seeing, you know, with our patients for that.
Are you able to tell us, Dr. Johnson, in terms of, I think our readers and viewers, listeners would be really interested to know, when you're bringing a new innovation like that into your clinical practice, when you're thinking about designing that trial, the one that you mentioned, how do you go about setting that up in terms of your clinical practice? So can you tell us a little bit about how you build the evidence for a new product?
Well, in this particular case, I'm relying on the people working on this before I got involved. You know, in the wound space, it's I think over 2 years that the article that was presented by Dr. Armstrong et al., you know, showed the N of 40, and that there was a significant shortening of time to heal for these difficult wounds. I look at it as, you know, what am I comparing the time to heal to, you know, and you know, whether it's a collagen dressing or whether it's, you know, something even, you know, simpler than that. We don't necessarily have the luxury to do a standalone trial where I'm going to compare it on my own, you know, a new product versus one of the other biologic cellular and tissue products. You know, the cost and the time, you know, to try to get an N of whatever, 50, 60, or 100 within the clinic. I don't think that the chief financial officer is going to allow that. Plus, I have an IRB that an institutional review board here at the facility that has to sign off on everything. So I would have to, you know, run it up the flagpole, so to speak, with them too. And I'm not sure that, you know, unless it was funding, that I would be able to take that on my own. But that said, if we can look for the evidence that's out there, and you know, there's you know, people are trying it different ways. I mean, this particular focus was on diabetic foot ulcers, but you know, what is the most common wound that we see in most wound clinics? You know, it's going to be a venous leg ulcer, you know, and I think there may be application there. We're trying to work with people in our physical medicine and rehab department, see if I can get the residents interested. Can we use it as a trial for, say, pressure injuries, you know, at different stages, maybe, you know, a stage 1 or 2, so that they don't become a 3 or 4. I'm also curious using it in the operating room. I think that there are going to be potential applications there. I mean, as a plastic surgeon, we do a lot of different things and touch a lot of different types of wounds, some acute, some chronic. And I'd be curious to see, you know, if there's a benefit there. I've kind of floated the idea of, you know, for donor sites, you know, for both flaps and skin grafts, and I've used it on a couple of patients for that, and been reasonably impressed with, the rapidity with which we can heal some of these wounds. So
Interesting. And what sort of groups of patients were you kind of choosing to try this sort of new technology? As in, what types of patients would you think, right, that would be someone who would benefit from a new innovation or new wound care product?
well, it would be the difficult to heal wounds. If it is somebody who's coming in with a simple laceration, I'm not sure that I would necessarily apply that. If it's a simple uncomplicated skin cancer excision with a primary closure, probably not there. But I think, some of these more difficult wounds, whether it's the long-standing diabetic foot ulcer, if they're offloaded properly and they're still not closing, if it's a venous leg ulcer that, has been adequately evaluated for both arterial and venous studies, and still we're having difficulty. And using it in combination with, offloading, if you're talking about the diabetic foot, 2-layer compression wrap, if you're talking about venous leg ulcers. And then where I guess I especially get challenged is some of the more unusual or difficult type of wounds. Pyoderma is one that sticks in my mind. I mean, pyoderma gangrenosum, for the 30 years I like to call myself a beautician. I did a lot of cosmetic surgery. I never saw it, but, opened my doors at the Mayo Clinic, and probably because that was a tertiary referral center, I was, some days I would see a half dozen patients with it, including patients who had had cosmetic surgery elsewhere.
Right.
So, I mean, and the challenge in treating that. So if there's something that you can, look at possibly being able to benefit. I mean, obviously, many of these patients are going to require medical care also, whether it's, prednisone, whether it's, a
systemic treatment.
Exactly.
Yeah. And what percentage do you think of those wounds that are difficult to heal were actually potential to have pyoderma as the etiology? I mean, in our clinical practice, we often see patients who fit that group of being difficult to heal. And again, it's one of those diagnoses that
I think that pyoderma is probably an underdiagnosed condition, and probably a little bit of it is because we don't necessarily think about it right away. And I think another reason is there's not if you were to do a punch biopsy, it's not a diagnosis that's going to come back and says, this is pyoderma.
Right?
What do they say?
The
They say
diagnosis of exclusion mostly, right? You're ruling out all the other things, and then you're like, okay, maybe this is pyoderma.
They always have that famous line at the end of the pathology report that says, please,
cannot rule out pyoderma.
Please correspond this with your clinical findings, which are often frustrating.
And I have a couple of patients that I've used it on with longer standing, for instance, hydroxyurea therapy, which they've been on for some myeloproliferative polycythemia or something like that, and they come in with these painful ulcers, and nothing seems to help, even when they're taken off of that drug. But actually using the Miragen product, I've got 2 patients that we were able to heal. One very quickly. And he had that for almost a year, and then the other one took longer, but eventually,
turned a corner. Yeah. And Dr. Cole, how about you? When you're bringing an innovative product into your clinical practice, what sort of criteria do you have in your mind, obviously in consideration for choosing to think, right, okay, I think of all the armamentarium that I have in my wound care toolbox, I feel like I need a new innovative product. What decision making is going through your mind clinically?
Yeah, I think we're always looking for the next best thing, right? And to fill a niche or a void that we already have in our toolbox, so to speak. We mentioned that the wounds that we treat are chronic and non-healing, right? So they're not on a healing trajectory. They're not following that pre-planned 4 stages of the wound healing cascade. So we need something to move them from wherever they're stalled back onto that healing trajectory, right? So we're always looking for something new and innovative. You know, I was interested and turned on by Merigen or borate bioactive glass a little while ago as well. I think it's very interesting and innovative because we're looking at this whole section of bioactive materials and kind of man-made bioactive materials. They have some pros and cons that, you know, some of the other products that are currently available in the space don't have a lot more pros. And I'm sure Dr. Johnson will discuss because he has a lot more clinical experience with the Merigen product. But, you know, we're looking for something that's easy to use, that's cost effective, that is, you know, effective clinically for our patients. And we're looking for a product that will help to support tissue repair and regeneration, all the things we need to help to turn on the light, so to speak, with cellular senescence, cellular proliferation, differentiation, angiogenesis. All of these things we know are lacking in stalled and chronic wounds. So I just, you know, I'd like to learn a little bit more about Dr. Johnson's experience with the borate bioactive glass and why you feel it's an exciting and new scaffold. I know you mentioned that you've learned a lot in the past year or so. And so I'm interested in learning a little bit more about how you fit it in your algorithm as well.
I don't think that it's a you know, a first line treatment. You know, I might have been close to that on a couple of patients, you know, just while I was learning about it, and I had some sampling. And you know, the toolbox tends to be big, you know, oftentimes because not every dressing or product is going to work for every patient.
It's not a one size fits all, huh?
Yes,
and that's
so
why I like it. I'm sure you do too, because you just never know. You have to figure out what's going on for that individual patient, right? So
right, and you know, there's, you know, what else do I look for? You know, I mean, there are some products or techniques that are very time consuming, and if you have a busy clinic, are you going to be able to tie up a room or a bed for 45 minutes to an hour to provide this? You know, storage, you know, some of the products need freezers, some need refrigerators, some have to be reconstituted. With Merigen, it's at least a 5-year shelf stable, you know, so it's just, you know, if you're looking for ease of use, if you're looking for efficiency in a busy clinic, you know, if you can reach up to the, you know, in the cabinet and take something out that, I mean, it literally, once the wound bed is prepared, it doesn't take, you know, a moment to moisten a dry bed. If it's a wet bed, you just leave it there, you put it on, it's porous enough that the exudate comes through. If you need to moisten it with you know, I use a hydrogel oftentimes if it's a really dry wound. If you look at what I've seen under the microscope, that there's 2 parts to this absorbable glass. There's a fibrin network that looks an awful lot like the fibrin at the start of the clotting cascade. And I understand that that is the part that probably dissolves pretty quickly, you know, is very quickly absorbed. And then there are some smaller pieces that hang around up to 45 days, I'm told. And again, I'm not the scientist. There's a fellow back in Rolla, Missouri, named Steve Young, that he knows all this stuff. He's into ceramics and glass, and you know, it's a silicate that is bioabsorbable. As I say, it's been in the orthopedic space for 3 decades. It's interesting because it has natural elements. I mean, boron, for instance, the borate, it's 53% of it, and it's believed that it stimulates angiogenesis. I've seen an incredibly robust granulation form, you know, in wounds that were stalled, and within a couple of applications, suddenly you go from that pink slimy look to a, you know, robust red granular look. They are doing some work now that suggests that it's very active and effective against biofilm. And I personally have seen patients that, you know, that some of these VLUs that come in with the green on their dressing, and you can smell it. And
From a mile away, you
yes,
know,
exactly.
Pseudomonas and everything else.
And literally within a couple of applications, 2 to 3 applications, the green is gone, the odor's gone, and you have this robust granulation. You know, so it drops the borate, calcium, which is, you know, one of the initial ions that we're going to need to, again, stimulate that healing cascade. That is a big part of it. You know, it's water soluble. You don't have something that when you look at the wound, say a week later, and you gently wash it, whatever residue is there, you leave alone. There you may not be seeing the granular wound, because it is being incorporated into the wound as the granulation forms. So you have to learn that a little bit, because, you know, you want
You
to.
don't debride necessarily in between applications, you leave it be, and do you apply on top of it then again, or?
Then I just cleanse it and reapply it. Just anecdotally, when we first started using it, one of our podiatrist who works with us, she would take take the curette to the wound.
Oh, I know, because that's what we love to do, right?
Yeah. And so what happens is you see this incredibly robust granulation, and guess what? The patients bleed now.
Yeah.
And so once we stopped doing that, the patient didn't leave a trail of blood when she was, you know, home. And it's you know, it makes this scaffolding that, you know, we want for our healing to proceed. I mean, that's my understanding, part of the reason we use different collagen based dressings, you know, part to you know, let the MMPs scavenge it, but also to have that scaffolding there to allow both the granulation and the epithelialization to occur. I just have seen a great deal of tissue growth in wounds that, you know, have been there a long time. I will say that the chronic wounds do respond a bit more slowly, which is not surprising. Some of the acute wounds that I've seen, I mean, within 10 days, you know, with you know, somebody who had a large abscess on their elbow, and, you know, I just packed some Miragen in there, and, you know, within 10 days, it was not only closed, it was closed. And so, you know, several instances like that. I've used it on some donor sites for both flaps and grafts that have responded much more quickly than I thought, and didn't need secondary procedures. You know, a skin graft donor site, you know, that's among the more painful wounds that we can create as surgeons. You know, I mean, where you put the skin graft usually doesn't hurt anymore, but that split
donor
thickness skin
site,
graft,
yeah.
that split thickness skin graft donor sites, you know, I mean, they don't like you for a couple of weeks, you know, and no matter
Like the
what-
worst sunburn they ever had, probably, right? That's what a lot of
so,
people.
yeah, and they used to fall off the bike and skin their knees. But I've used it on a couple of patients for that, and it was amazing. At 4 days, there no pain. I think that's still a work in progress. Again, it's so I use samples on that. We'd have to figure out, you know, how that would work in the operating room on a regular basis. But I've for 40 years, I've been looking for the better or best or perfect dressing for the skin graft donor sites, because there's tremendous morbidity with that. And if you're not careful, you end up with, you know, a full thickness wound there and the like. So
Yeah, and we don't want to be responsible for causing a wound while we're trying to heal a wound, right?
I like
That's
to tell
the worst.
patients, I like to tell patients that we are, you know, a wound clinic, but we try not to create wounds.
No, I think you've brought some slides of some cases. Megan, is it a good idea now to have them shared with us and go through?
I'd be
I think that
happy
would
to do that. So these are,
Yeah.
I've used it in probably about 35 patients now and about 42 different wounds. And these are just some representative examples of some of the applications that
I got a sneak peek at them, and they're pretty impressive. So I can't wait for you to walk us through them.
Okay, so whenever you'd like.
Great.
So this is a story of a patient who is about 74 years old. She was native to Mexico. She had this wound, and we could never determine, nor could her family determine, the exact etiology. Was it a bug bite? Was it trauma? Was it something else and had been there over a year. She had been using, let's just say, local homeopathic type of remedies. And her daughter finally said, enough, that's not working. Can we please bring you in? So the initial photograph here, that yellow is not just slough, that is the bone there. So we got x-rays, we ruled out osteomyelitis. This, I should add, is in her pretibial area. Was somewhat painful. She surprisingly had never had an infection or cellulitis. As I said, I got x-rays, there was no evidence of osteomyelitis. So we did the cleaning that we could and started applying the Miragen. And you can see there a month later, we're starting to see a little bit of improvement in it. And this was simply probably every other week, just because of logistics of having her come into the clinic. We would apply Miragen. It was a small amount. It was, about the size of the end of my little finger. The actual product is very interesting to work with. If you look at it, and again, if you can think about, bioactive resorbable glass, most people are going to think of either a glass window pane, or they're going to think of the fiberglass insulation that's in their house. Well, this comes out, and when you remove it from the packaging, it has a consistency almost like cotton candy. It's very fibrous. It's very thin. It's not going to blow away, but if it's a dry wound, you have to be careful so it doesn't fall away. And
sounds like it's malleable though. So for a deep wound like this, it would be able to pack it. Is that right?
That is what I did. So you pack it, you leave it there, you let it drop its boron, its calcium, its magnesium, and hopefully it's working on the biofilm and reducing that. And I think it did, because in less than 2 months, this wound was now closed. This photograph has a little bit of white still on it. That's just the residual Miragen from an application 2 weeks before. And when I first started seeing her in October, she would barely let me get close to the wound, even if I did a topical anesthetic or injected. It was very painful, and it no longer is. There's no longer any drainage. And, a year plus of having this, we have now closed this wound. So I thought the fact that it was down to bone and we were able to granulate over that and, eventually come to closure was, I think that's pretty impressive. I'm not sure what else I could have pulled out of the toolbox that was going to let me do that.
No, in 2 months, that's definitely impressive.
And how often did you change the dressing, Dr. Johnson, on this patient? How long would you typically leave in this sort of clinical scenario where obviously there's inflammation, there's bone at the base of the wound, and it's what looks like quite a deep cavity with, I guess, punched out edges in terms of induration?
It was about 1.2 centimeters deep. Right. And I would change this about every 2 to 3 weeks. I think I could have done it more frequently, but it was just, there were transportation issues and the like. So we did this, let's call on average about every other week, we would apply the product.
And how flexible is it in terms of being used with other adjuncts in wound care? So are you able to, for instance, use topical oxygen over that dressing, or are you able to use any other adjuncts?
I think you could, I have a couple of patients that we have used it with hyperbaric oxygen therapy. I had a 95-year-old patient who had a transmetatarsal amputation that dehisced, and we were able to pack his wound. He actually had, let's see, the lateral aspect of the incision dehisced, and then there was tunneling of 5 centimeters towards the first metatarsal head, and or first metatarsal, and combining that with the hyperbaric oxygen therapy, within 3.5 to 4 weeks, the tunneling was gone, 0. And the other wound was nearly epithelialized and contracted. And about 2 weeks after that, he was good. He had no more drainage. It was, I thought that was impressive too. He had originally been sent to us for hyperbaric oxygen therapy because of the poor circulation in his dorsal flap. after the transmetatarsal amputation. Again, 95-year-old man, he did not want to have a BK amputation, so we felt that we had done a good job there. And he was growing out an E. coli
Oh,
at
wow.
the time of his dehiscence, and he was never placed on antibiotics, either oral or parenteral. It was again, I'm not saying that it's an alternative to antibiotics, but I do think that there is a significant antimicrobial effect here, and I know they're working in the lab on that to try to define what the 10 to the whatever log kill is there for that. So, but this was one case out of the 30 some that we've done. I believe, Wendy, there's another one down there.
Yeah, and I was thinking you could probably utilize this under negative pressure wound therapy too,
Sure.
right? Because it's a scaffold, you would think then it gives that granulation tissue something to kind of latch onto. And if it does have some bactericidal properties, we know that when we take off a wound vac, sometimes we just smell the bacteria. It's just a perfect breeding ground. So it might be well utilized in negative pressure. Have you used it that way?
I have used it on several inpatients, yes.
Okay.
Yes, so
Dr. Johnson, so you used the Miragen dressing, and then on top of that, what did you use?
I was using let's see, either a foam dressing, or I was using I don't know if we're supposed to say brand names. I used a self-adaptive dressing that used also, and that's one that I picked up, from my nurses at the Mayo Clinic, who were a lot smarter than I am. And it was one, that if it's a dry wound, it adds moisture. If it's a wet wound, it's highly absorbent. So I used that there also. Yes.
Thank you.
So this next patient is a young man who came to us for treating his venous leg ulcer. He had not had one in 6 years. And he came in with his primary worry was he would play poker most nights and sit there for 6 hours. And so he had this draining wound here that he wanted us to treat. So we, did the vascular workup. Took a while to get him into a vascular surgeon. This was multiple applications of Miragen, coupled with the corrugation you see there is, I've gotten into the Dr. Winkler's product, Edema Wear. And
The fuzzy whale, so that it.
Fuzzy whale, yeah.
It's good stuff.
Dr. Mark
Mark
Malin
Smith.
introduced me to that.
Yeah,
And,
it's good stuff.
I've grown to love it. It's another one of those innovative products, new to me, that I think is helping patients. So we combined that with the Miragen, and we did a 2-layer compression wrap. This took probably about 10 weeks to get this result. I don't think that we were completely helped because, again, he plays poker for his, that's his outlet, and he will not, probably 4 to 5 nights a week, he is sitting at a table. I said, is there any way you can elevate? He says, no. He says, I've got to be there.
It's not cool in poker to do that.
I've never played, but he says,
I'm assuming.
I have to, because I have to be able to hold my cards and be there to see. So this is it. But he's very thankful. Every time he sees me, he says, thank you, doctor. Thank you, doctor. And the nice thing was, occasionally you'll see a comment from patients the first time you put it on that there may be a little bit of stinging or burning. Usually after the first application and after a couple of days, that is not, it's just not something that's commented on. The company seems to think that it has to do with it. It's changing the pH of the wound bed as it drops these ions. And I don't say that I'm the authority on that, but I was warned as I started using it that, you may have some patients who will comment about that. And indeed I have. It's not every patient. It's probably 20% probably that might do that. So that might be something, if you're going to use it, you just might mention it, but he never complained about that after the first application. And he is so thankful that we have gotten this wound closed, and he's actually scheduled for his venous ablation Monday, and then we'll hopefully be able to just put him in, the edema wear and the compression wraps after that. And he's most thankful. I mean, patients with this amount of exudate, that might need to have their 2-layer wrap changed 2-3 times a week. Everything gets soiled. They have trouble wearing clothes and shoes because there's so much drainage. So it's life altering. And I think the combination of the Miragen with the edema wear with the compression wraps, I think we were able to get him closed, and it was a relatively rapid closure on this. So
I mean, it looks like it was involving, I guess, a distal third of that right lower leg. So in terms of surface area that you've covered and healed, it seems to be quite significant, doesn't it, compared to, I guess, the first patient you showed us?
it was like about, I want to say the length was at least 15 centimeters.
15 centimeters,
and
yeah.
the width was probably about 8 or 9, as best I can recall. Yes.
Right, and that looks like it's extending past the midline posteriorly as well in terms of.
It was, yes.
Right, and anteriorly, obviously, there's a tiny bit of what looks like normal skin sparing anteriorly, but it's quite a large area to treat. So yeah, well done on managing to get such a good healing result in that one.
Yeah, and I think you made a great point about the long-term use of some sort of compression garment, right, in these patients, because we know the recidivism rate for a wound such as this is so high. We see these folks time and time again in our clinic, and without having a plan of action once they heal, we're bound to see them again. So I think that's a great point that
he went out and bought 4 pair or 4.
Did he? Good.
So he just keeps them clean.
He's ready. He's ready for poker night all 5 nights a week.
Yes, indeed. So this is a little different wound. It's I guess putting on my reconstructive hat. So elderly gentleman, a little bit, let's just say mentally challenged. He was living in a group home, and he came with this lesion that was highly suspicious for carcinoma, which indeed it was. It took a little while. You see the dates, the length of.
And this is on his distal nose that we're looking at, right? Is that correct?
Right on the tip of his nose, yes.
Okay.
And there was a little delay getting him in for treatment just because of the group home situation and some hoops we had to get through to get him medical clearance, et cetera, et cetera. So I took him to surgery, did a wide excision biopsy. In the operating room, they said I had clear margins. The permanent section, unfortunately, came back positive margins. So what you see next is I had Miragen, I put it on there. In an attempt to stimulate granulation. It's also very hemostatic, I've found. So for a fresh wound, it's and the nose, once the epinephrine was going to wear off for where I had injected the surgical side, I was worried that we may have an issue with bleeding. Again, he was going back to the group home. They don't have on-site nursing, and so I was just trying to be a little bit preemptive there in doing that. So that was, it's plastic surgery, and we go back to they like to teach us that what we did to reconstruct this was the original plastic surgery, the old Hindu rhinoplasty from the Sushruta papers, so 2,500 years ago. So
I just wanted to say, in terms of aesthetic subunits that were involved in this, obviously for our listeners who won't have the benefit of seeing the slides, in terms of the aesthetic subunits, are you able to tell us which ones were involved? So it obviously looks like it's extending beyond the tip, possibly supratrip and dorsum of, it looks like dorsal involvement as well.
That is correct. The entire tip was gone. Portions of the caudal septal cartilage were removed. Basically, the entire left alar cartilage was removed, and that anatomic unit. It was a little bit less involved on the right side, but we had to take about the entire medial crus of his right alar cartilage, and then about half of his lateral crus. And then on the dorsum, it extended basically to the demarcation between the cartilage and the bone on the dorsum. And this was, again, here they said I had clear margins, and I didn't. I had to take him back to take additional tissue. So
to do a wider excision. And then you used the dressing, and then you came back and did a forehead flap
that is correct.
reconstruction.
That is correct.
Right.
And
right.
this is the forehead flap is more on located on the right side. You can see the outline of the flap. I ended up doing a paramedian flap.
So it's like a right paramedian flap.
Yes, because he actually had treatment for a skin cancer. There was a large scar there. You can see kind of a whitish area just to the just medial to my outline there. So we outlined that, and I got clear margins finally, and we were able to elevate the flap and then rotate that. So I think you have the next slides that will show that. So I guess that I should also say that middle one, that middle slide there shows the wound prior to the re-excision. This was on a prior one, but right on this set of slides, I have the flap elevated. I was not able to completely approximate the forehead, so I had an open wound there. I did not want to put a skin graft on that time. Typically, once you rotate the forehead flap, you like to keep it in place about 3 weeks before you divide
the flap
and inset it. So I thought, you know, this is again another donor site application that I did. That's the central slide here. And I had about 1.5 centimeters that I was unable to bridge that forehead donor site. So I packed it with Miragen. When the patient returned for follow-up at a couple of, I want to say it's about 10 days there, the Miragen was completely absorbed. I had not cleaned that wound that you see on my right there. You can see there was some retention sutures trying to bring it together or hold it together. I reapplied some Miragen, and you know, he was going to go for a total of 3 weeks before we did the division and inset. But I think you can see the granulation that has.
Yeah, it looks pretty healthy, and it's almost overcoming those retention stitches, right? So it's kind of up against them, so that's good.
I mean, yeah, it's coming from the depth of the wound, and it looks like it wants to come from the edge of the wound also. So I mean, this was that, I think I mentioned earlier, used the term robust granulation. I think this is another example of that. So I think there's another slide.
Impressive. It's a pretty impressive reconstruction in terms of both your, you know, the contour that you've matched for the nose, and also if you look at that superior portion of that donor site of the flap between your, sorry, can we go back one slide, Wendy? Impressive to see that donor site closure superiorly. You see, it's quite a significant gap. It looks like
there still is.
Perhaps there was a gap of about 3 or 4 centimeters. But if you look at the photograph on the right, which is your post application, that's really closed extremely well.
Well, it came together nicely in the operating
superiorly.
Yes, and it's going, and that's let's see, 6 post-operative days, 5 post-operative days that we're seeing on that slide.
Fairly quick, yeah.
That's like I say, it's robust granulation. So
we like that term.
Absolutely.
So this was correct. So then on the left-hand side, this was again a visit just prior to his division and setting, and you can see the granulation has basically covered the retention sutures. So that would be about 2.5 weeks out. And you see a little bit of the residual Miragen still sitting at the base in the glabellar region there. And then when you divide and inset, you know, what went back to his forehead was what I didn't need. The remainder that's on his nose, you know, it's swollen. We expect that, you know, at some
point. You re-inset back into the donor site.
Yes. And I thought initially, when I did this case, I figured I was probably going to have to do a skin graft to close that large superior donor defect. And you can see where we were at this point, and it has subsequently gone on to completely epithelialize. So there was no need for additional skin grafting. He'll have some additional revision down the road, probably just to debulk this and the like. Will give this 4 to 6 months to settle out. But, you know, just from a donor side, if you go to the left-hand side, which is still quite deep and wide, you know, it's
Yeah,
there's no canyon there anymore. It has
it's quite
granulated and
reconstruction.
filled in. And I think you, again, you may get a little more, the granulation may be a little bit more robust or aggressive with an acute wound than it might at some of these more chronic wounds that, you know, we tend to, you know, experience more regularly with our wound clinic. But nonetheless, I've seen it in nearly every one of them. If we can get them, get the bed prepared, try to get it, you know, back to a new day zero, and then try to treat. It's, you know, it's just been a very, very nice tool to work with. You know, it's good to have that tool in the toolbox for some of these patients, and it's been fun to learn about it. As I said, if you'd asked me in July about bioabsorbable glass, I would have scratched my head and, you know, wonder what you'd probably been drinking or something. But, you know, as I've researched it, as I say, it's been around for, you know, 3 decades in the orthopedic space, and they use it there for, it's a little different formulation, but they use it there to bridge bone defects. And I don't know, Wendy, if you've ever been exposed to that, you know, in your podiatric world dealing with bone loss, but I talking to some of the orthopedic surgeons, they have said, oh yes, we experienced that. And I understand it really got a big push during the first Desert Storm wound, you know, where they were taking.
Oh, really? No, I don't have any personal experience with that product and that mechanism, but it would make sense from what we're discussing that it would work for osteoinduction and osteoconduction as well, and bony defects.
Again, I think it's another tool. You know, you don't have to harvest skin and, you know, have that emulsified or whatever they do. You don't have to draw blood and spin it to get it. It's available. It's, you know, it's easy, you know, 5-year shelf life. It's doesn't require refrigeration, and it literally, to put it on any one of those wounds, it didn't take but a minute. Maybe
I think that's an important point, because I feel like the more steps to a product, the less adoption we have, because it disrupts the clinical workflow. And you know, everyone's busy. You're trying to give the best care to the patients, and, you know, get to the next patient and stay on track, and, you know, not keep people in the waiting room too long. So I think that's a good point.
Effective but efficient. And again, it's I'm kind of excited to see what other work they're coming out with, you know, from the biofilm / antimicrobial world, which I didn't show those patients, but you know, we had several here, as I say, had, you know, green drainage, green wounds, the odor, and within, you know, just 2 or 3 applications, that was gone, and you were no longer dealing with that pink spongy granulation tissue. You know, you had that robust red granulation tissue that, you know, you need to facilitate healing.
Yeah, and with the antimicrobial, or I should say antibiotic overuse, and antimicrobial stewardship protocols that we're trying to push in our clinics, I think this might speak to that as well. So I'm curious to see what they can prove and what they show as far as that goes as well.
Right. I mentioned that patient earlier that, you know, had a positive E. coli swab, and, you know, with a 5-centimeter tunnel, 95-year-old, you know what his circulatory system was like. And
yeah, not good.
He closed that without any antibiotics, parenteral or intravenous. So it's something else to think about. Yes.
Yeah, Dr. Johnson, thank you so much for sharing those clinical cases with us. And, you know, we really admire the fact that you have such innovation, and that you're so receptive to obviously improving practice by looking at new technologies. And Dr. Cole, thank you to you as well. Obviously, you're a big advocate of bringing innovative new products into your clinical practice as well. And, we thank you for sharing your experience with us and with our listeners. So again, we'll look forward to looking at the further trials that you have planned, the multi-center trial, and we would love to catch up with you again once you have some more results in the
Anytime.
future as well.
I'd
Thank
be
you very
happy to
much for
share
your
it, so
time.
Thank
Yes.
you.
Thank you so much for joining us
you.
on the Wound
Yeah, it was
Masterclass
fun.
podcast.
That was a real eye opener.
Yeah, that was really interesting from Dr. Johnson presenting his patients that he's selected for this innovation. And also it was really interesting to hear the evidence behind making decisions like bringing that kind of innovation into his clinical practice. So I really enjoyed that, and it was really helpful visualizing that as well, wasn't it?
Yeah, really interesting to see the variety of cases he shared with us.
Next week's episode of our Wound Masterclass, the Wound Masterclass podcast, is going to be introducing another innovative concept. So we're going to be excited to bring that to you next week. Don't forget to tune in for that. And if you missed our last podcast, which was the first one, don't forget you can download it, and we'll include the links down below.
Yes, and you can find all the episodes of the podcast at woundmasterclass.com/podcast, as well as lots of other stuff. So thanks for listening and watching.